Good morning, ma'am. Today we are going to continue with the same myocardial infarction. So the remaining chapters which we are going to cover is that on the diagnostic intervention of how to identify a patient with history of myocardial infarction and what are the possible managements. So under management you can divide it into four major criteria. One is the medical management, which is going to start with the drug interventions. Then you have the surgical management, followed by that you have the dietary management, and last but not the least, nursing management. So going on with the session with diagnostic studies. So what is diagnostic study? Anyone from the group? Yes, Jason, can you say what is diagnostic studies? Very good. Clap hands for that. So, as he said, it is exactly right. So, to find out whether the patient is having only myocardial infarction or any other differential diagnosis, such as treating case of esophageal varices, gastritis, or any musculoskeletal pain, also patient can have chest pain. But to exactly conclude that the patient is having myocardial infarction, we will be having certain diagnostic interventions. So first and foremost, as we all know, we collect the patient's history. That is history of pain. The history of pain, what are the major mnemonics which we have seen in the last class? Can you please explain on P, Q, R, S? P is provoking factor. Quality of pain. Okay, very good. Right. Assessment of pain, as well as we are going to screen the risk factors, and we will be also checking on the health history. So health history, we are going to ask the patient about the previous histories, such as medical history, past medical history, past surgical history, and as well as their social habits such as smoking and alcoholism. As we saw in the risk factor, those two play a major role. And about the stress pattern, obesity, all that we can cover in the health history. And of course, as we are swimming through cardiology, definitely we have to go in for ECG analysis. So in this ECG analysis, we can exactly depict where the blood clot is present, whether in the anterior portion of the chest, cardiac muscular chamber, or in the posterior or in the lateral sides, just with the help of ECG. And of course, we have to confirm with cardiac biomarkers. So there are four biomarkers such as troponin T, troponin I, CPKMB, as well as myoglobins. So these are the four things which we will be seeing in the serum cardiac biomarkers. In last level it is 1 or 2 days before, or maybe 1 month before, like that. So just go with the graph. So where you have three colors, one is blue, the other one is red, the other one is green in color. So on the x-axis you have the days and hours calculation by biomarkers value. So on the x-axis, all the that is troponin I, myoglobin, CPK, all these bioenzymes are being released in 0 hours itself. That is as soon as the chest pain has started. But you can see in this, there is a peak increase in myoglobin on the first day, that is on the 0 hours, and you can see it is declining on the second within 6 hours, and followed by that there is a drastic amount which is being released to the bloodstream. So that we call it as, like we can identify whether the patient is having acute level. Within 0 to 6 hours only it is high. Then after the 6th and 7th and 8th hour it is coming to near normal, which shows that heart activity has been damaged initially itself. So if the patient is coming on the 4th day or 5th day, we cannot diagnose whether the patient is having acute level. We can easily say we can speak on with myoglobin, instead we can plan in for CPKB. Then CPKB is nothing but creatinine kinase membrane bound. It is an enzyme which is released when there is heart myocardial injury. So here this is being slowly rising. It is not suddenly rising. Can you see the green color curve which is starting 0 hours, it is not elevated, but on the second hour, how might be after 1.5 hours. For example, if a patient is having chest pain at 8 o'clock and he is coming to the hospital and you take a sample of CT cable. But during that time the patient's value is normal or near normal, but the ECG is showing variation. Then after 1.5 hours we have to repeat the CT cable. Definitely there will be a peak. It is a golden opportunity to immediately start with intervention. The same thing when you compare with Brammu.D, it is increasing gradually on the 0 day itself, and it is all dormant high in the blood levels and it reduces by 4. If the patient is saying that during maybe before 10 days I had pain, and when the patient is coming to your hospital, might be you can take an ECG, 12 ECG, one changes is shown, but if you see that it is all these 3 enzymes will be very low. Either it is mid twice the normal value or might be it is very low than the expected raise of value. That was 2 days or 4 days or might be more than that. That explanation I already given. As we all know, the myocardial layer is not only present on the atrium as well as it is coming below to the ventricles as well. So here, the ventricle chambers, it is not only in the anterior. You can see that it is located on the posterior side, on the anterior side as well as the lateral side. So here, this is a picture of 12 ECG, where you will be having 3 leads, lead 1, 2, 3, followed by the augmented leads, which is the limb leads, AR, AVL and AVL, followed by that you have the chest leads from V1 to V6. So in this, yellow color which is depicted, that is lead 2, 3 and AVL. If there is a ST segment elevation, ST segment depression or the formation of T wave, which indicates the inferior portion of the heart is being affected. What is inferior? The lower portion. So this is to make a fist of your hand. So you can divide it as superior and inferior, anterior and posterior and lateral. So your inferior portion of the ventricles is being affected. Just by looking the ECG, you can say yes, patient is having the lower portion of the heart being affected, which shows that no need to go for artery. Definitely we know either the left anterior descending artery or the posterior descending artery is being affected. Then you have the cream color codes where you can see that the ST segment elevation, depression or formation of a T wave will be seen T wave depression in V1, AVL, V5 and V6. So if these 4 leads you have any PQRS changes deviation, which shows that patient is having lateral wall elevation, that is either on the right side or on the left side. The sides of the myocardial tissue is now deprived of oxygen. Then you have the anterior wall, or we call it as the anterior leads, where there is changes in V3 and V4. If there is any PQRS changes in V4 and V6, the V3 and V4, which indicates patient is having anterior wall, that is towards the forward portion of the arm. Then followed by that you have V1 and V2 changes, which shows that it is the septal wall area, that is between both the atrium and the ventricles, either the upper atrium septum or the lower atrial septum, the patient is having myocardial changes, that is infarction. So just looking at the ECG, PQRS changes, and wherever it is located, if you find a PQRS changes in V2, 3 or AVL, it indicates that it is inferior wall area. If there is changes in V1, AVL, T5 and V6, it shows that patient is developing lateral wall area. And if there is changes in V3 and V4, it shows posterior wall area. But that is only located to the posterior side. Normally how we take ECG? We make the patient on a light flat surface. We keep all the limb leads followed by the chest leads. But in case to identify if the patient is having posterior wall area, we have to remove the lead 4, 5 and 6 in this portion on the anterior face. Instead, those electrodes are being placed on the posterior wall. tolerate or please cooperate, let me take the proceeding easy. So patient is on a lateral surface. We are placing all the new leads followed by V1 to V4, then V3, then V4, V5, V6 is alone. Placed at the posterior side, fifth intercostal space, leaving on the bone spaces. Scapula should not be involved. With that also we can diagnose. So if there is changes in V7, V8 and V9, and those are recorded as V7, V8 and V9, and that if you see any video or changes, we call it as posterior whatever. So totally there are 5 types of MA, right? Or emergency management, as this is a very emergency life-saving procedure. So what management can be done? There is a small mnemonic for you to remember. A girl named Mona, M-O-N-A. M for morphine, O for oxygen administration, N for nitrates, and A for antiplatelets and anticoagulants, right? Can you follow this? M-O-N-A is M for morphine, O for oxygen therapy, N for static with nitrates, which is vasodilators, and A for anticoagulants and or antithrombolytic agents, which can be static. So here the morphine is that it is a narcotic sedative and it is very much cardiac friendly. That's the reason why we are choosing morphine. So here the patient's pain as well as anxiety can be reduced and the common dosage of loading dose will be up to 5 mg IU. It is not IU, so up to 5 mg we can dilute and we can give slow IU. Followed by that we are giving a loading dose of aspirin. Aspirin is the antiplatelet. So here we are giving starting from 162 mg to 325 mg per OD. So here there is high risk for aspiration when you are giving this drug. See that the patient is fully conscious and you explain the patient that I am going to give the drug. Are you able to understand? You have to swallow and don't give bulk of water. You have to give only sips of water and the tablets is all very huge in size. So you have to tell them you break it and make them to swallow with only sips of water, not engulfing large amount of water. Because if they drink many water and if they are going for cardiac arrest, risk for aspiration. Make the patient in a full sitting position, this powerless position. Then for preventing the thrombus as well as emboli, we are giving this drug, this antiplatelet, followed by the oxygen therapy. Because we all know that myocardial infarction is called increased or deprived of oxygen. That is the only first reason why the tissues are going for necrosis. So here oxygen it started with 4 liters by nasal prongs method, and in case if the patient is not tolerating, then you can plan for NIV, non-invasive ventilation. If still patient is not tolerating, then we have to plan for intubation. Then followed by that we have to plan for IV fluid administration. So IV fluid administration is not that easy. You have to do a bedside echo for the patient. If the patient left ventricle ejection fraction is more than 50, then we can plan for IV fluids. If it is more less than 50 or less than 30, then totally we have to restrict the fluid because already heart is not pumping effectively. And if you are going to increase fluids by IV, what will happen? More and more volume return to the cardiac system. That way, what will happen? The workload of the heart will be increased and more chances of cardiac arrest is risky. So IV fluids must be given only if it is tolerable and if there is no fluid volume over. Patient is having myocardial infarction. Immediately when you receive at the emergency department or in the ICU or in the OPD, start with ATG spray, especially just below the thumb, sublingually for fast absorption. Then you start with phototherapy either by nasal prongs or non-invasive ventilation or by intubation, and start with admission procedures and all the antiplatelet and anticoagulants to be started such as aspirin and thrombolytics. During hospitalization, when the patient is in the hospital, you can plan in for starting with beta blockers or basic inhibitors, and if the patient is having no diabetes, start with insulin therapy, that is with the fluids. Followed by that, we are planning for management. So the management is either class D, angioplasty, or placing a stent inside the coronary artery or by arterial bypass, which is CABG. And now that is, even after, as I told you in all the classes, like even after the remedy, after sucking out the blood clot, still there is high risk of re-emergence. So in order to avoid the re-emergence, patient will be on long-term therapy such as aspirin, beta blockers, and some AC inhibitors to enhance the cardiac output. And you have the atorvastatin drugs to reduce the lipid level. And they have to follow the health irrigation process, which is like on the lifestyle measures. So lifestyle measures which includes all their dietary pattern, their social pattern, that is whether they are drinking, smoking or alcohol or smoking, or they are having quite frequently outside foods, all that should be avoided. And of course, salt restriction, because if they are having high amount of salt, high risk for hypertension, which may lead again re-emergence, as well as salt restriction is enhanced, because in case if they are taking more salt, that is all the water molecules will be absorbed in the tissues. That way patient will be developing edema. So in order to avoid that, salt restriction is important. As analgesics, anti-ulcer and antidepressant. And the common therapy which we do is that I was saying that it was stent procedure, or you call it as angioplasty. So an angioplasty, what they do is that they found where the clot. I think in this picture they are shown there is a clot in the LCD, that is left coronary artery. So they are inserting the balloon along with the stent. First balloon is inflamed, then you can see the stent is also going a little wider. After that the balloon is deflated, and the balloon as well as the guide wire is removed, and only the stent is alone placed inside the patient's coronary artery. This is the fibrinolytic therapy. So this will be seen in later classes. Drugs on gene therapy. So gene therapy is nothing but we are going to do the vascular endothelial growth factors directly injected into the bloodstream. That way it is enhancing the endothelial layer of the coronary artery. Starting with copper chelation therapy, it is going to reduce the chelation, means it is going to remove something. So what it is going to slow down cell proliferation in the endovascular layer. Or we can plan with radiolytic thrombectomy. Here it is done by 7 jet wash of the coronary artery. And finally we can also do the clot aspirator, which they use as an Endicott exciser aspirators can be used. If all the above measures fail, we have to plan for CABG. CABG is coronary artery bypass graft. So here coronary artery bypass graft, they will be using some of the heart lung machine. If the patient is on pump in the sense all the blood from the patient's body is being redirected to a machine. And instead of the heart and the lung working, the heart is made very still. It is not going to work anything. It is in the form of a dead vegetative cell. And all the repair will be done. Once the repair is done, again they will be connecting the blood to the patient's body, reconnecting, and they close the full heart chambers. So this here we got it as on pump. During this process, they see that the blood is not clotted or lysis, because we know as soon as the blood comes out, what happens? Due to atmospheric pressure as well as due to the nature of the blood cells, it will try to coagulate, that is lysis will take place. In order to avoid this, patient will be on continuous anticoagulation drugs during the surgery. You can see patient's body temperature will be maintained, patient's fluid status will be maintained, ABG analysis will be done before, during the procedure as well as after the procedure. So who are the patients who are going for this condition is that angina with 50% occlusion of the coronary artery, unstable angina cases, ischemic cases with heart failures, acute turbulent cardiogenic shock, and valvular disorders. So patient's body without taking air. So So this is fully being care taken by a perfusionist. We won't be doing the majority work here, but you have to know how the heart machine works. That is being joined with the coronary outside. So the three types of surgery what we do is that on top, off cap, or we call it as the mid cap surgeries. Coming to the dietary management. So as the patient is going home, we have to teach them on the importance of what are the fats they can consume, what are the diet items, total calories intake they can take, how much fiber to be taken per day, all that will be explained. So the last but not the least is nursing management. So as we all know, we introduce the detailed history and physical examination, followed by that. If it is a pre-operative, we will be diagnosing the patient pre-operative diagnosis, and if it is a post-operative, then post-operative nursing diagnosis can be planned, and intervention can be done in the framework. So here the nursing diagnosis is acute chest pain related to the injury of the myocardium, decreased cardiac output related to LV dysfunction, activity in progress due to decreased cardiac output, that's a small spelling mistake. And then ineffective tissue perfusion related to decrease in coronary blood flow, and we can also write a diagnosis as ineffective renal perfusion related to decrease coronary blood flow, impact gaseous exchange. This is followed by surgery, and patient is always knowledge deficient, so you can explain on how to do later when they resume the normal activity, when they can join the work, when they can start their family activity, reproductive activity, and so on, and risk for complication related to decreased cardiac output. Can I have some question session? So what can anyone explain on the Mona dispatch?